This seminar tonight is on this very large topic of gliomas. Of course, there are lots of other brain tumors out there that we treat, but this will focus on gliomas. And of course, within this topic of gliomas, this is an enormous area to talk about. So there's a lot of things that we could go into. What I'm going to try to do is give sort of an overview of things that I think would be of most interest to you. And then just to remind you, next week, we will dive into this further and we'll go through a few cases, and that will really dive into what treatment is like for these gliomas. Again, encourage you guys to use that Q&A box to add your questions, and at the end, I'll do my best to go through those in the time that we have left. Okay, so here's a list of objectives. This does not exactly match the objectives listed on the website for the training center, but I think it is still going to be a comprehensive coverage of this topic. So let's get a definition out there for diving into this. So gliomas are the most prevalent primary intrinsic tumors of the brain and spinal cord. Histologically, they share characteristics of normal glial cells. So we're talking about cells like astrocytes and oligodendroglia. However, whether gliomas originate from normal glial cells, glial or neural precursors, or stem cells, or other cell types still remains a topic of investigation. If you just quickly Google glioma MRI, you're going to quickly get a sense of the diversity of tumors that are out there. So the way they present clinically, the way they look radiographically, and of course the types of glioma is incredibly diverse. So that's why we have a lot of colleagues out there who really focus just on gliomas and are truly glioma surgeons, because it does take a lot of focus and expertise to handle this category of tumors. So what are the possible gliomas? I think the best way to kind of define them is to look at the World Health Organization's classification scheme. And I just want to point out that in 2016, there was an update for that classification, and that was updated from about 10 years ago. And you can see the red additions here with lots of changes. And if you just kind of step back, you'll see that in red, the most common things are genetic mutations. So for the very first time, we are now using genomic data to really define meaning gliomas. So very quickly, let me just skim through this list here. So on the left, here are the diffuse astrocytic and oligodendroglioma tumors. So diffuse astrocytomas, anaplastic astrocytomas, glioblastomas, and you'll see they're further subdivided into IDH mutations and wild type. We'll talk more about that later. There are a few sort of oddities under glioblastoma, which are referred to their histology. Moving down the list, there's this unusual diffuse midline glioma in the younger population that commonly has this specific mutation, H3K27M. Here's your oligodendrogliomas, and they can be defined by IDH mutations and 1p19q chromosomal deletions. Of course, there are anaplastic versions of that. There are these mixed versions. Moving over to the right, here are some more astrocytic or glioma tumors, like the Pilocytic astrocytomas, subepidemoma, giant cell astrocytomas, pleomorphic xanthoastrocytomas. Ependymal tumors are on this list. We're not going to talk about those, but just keep that in mind. There they are. Other gliomas include these choroidoid gliomas and a few other odd ones. And then there's a list of mixed neuronal and glio tumors. So the bulk of these gliomas are here on the left, and that's really what we'll focus on just for this lecture. So that classification scheme defines those tumors as we were just going through, but then defines their WHO grades. And so the grading system is important to think about. So there's grades 1, 2, 3, and 4 that you've heard before. And just to quickly remind you, so grade 1s, these are tumors that have low proliferative potential, very discrete on MRIs and in the brain, and possibility of curing them just simply with good surgical resection. Grade 2 tumors have more atypical cells, more infiltrating nature, but still have a low mitotic activity. They do recur more frequently than grade 1 tumors. Some of these grade 2 tumors can progress to higher grades of malignancy. Grade 3 tumors. So this is where we start to see histological evidence of malignancy, such as nuclear atypia, anaplasia, increased mitoses, much more infiltrative capacity. So these tumors require post-operative aggressive adjuvant therapies like radiotherapy and chemotherapy. And then, of course, the very common grade 4, these are the most mitotically active, have necrosis, have a lot of neovascularity, very infiltrative, rapidly progressive, and require aggressive treatment and universally fatal. So all of those gliomas that we just went through on the prior slide can be graded 1 through 4, and that's very important to help with prognosis and with thinking about appropriate therapies. I threw in this slide because I thought this was a good illustration of something from this classification scheme. So as I was telling you, all these gliomas can be classified by the specific type of glioma and then by the WHO grade system. But it's not a perfect system. So for example, some of these tumors correlate very, very well with what you would expect from the grade that they're placed in. So the way they represent it here on this picture is there's a very clear line demarcating the green color from the orange color. So tumors that are correctly diagnosed and put in this category clearly behave like grade 1 tumors. So we have a good classification scheme for these tumors. If you go to the right, over here, you can see that there's a blending of the color. And so what they're trying to suggest is our classification of these tumors is poor. There's a poor correlation between what we are calling these tumors and their behavior. So in other words, we need a lot more work out there. So that's another reason why I'm throwing it out there to you guys is if you're looking for areas to explore research, these tumors need better classification schemes so that we can place them in the proper grading system to help with prognosis. But of course, that further study will lead to understanding those tumors better and better therapeutics. So why use this WHO system? It's a very reproducible grading system, strongly predictive of patient survival. So as a rough rule of thumb, for example, if you can place one of those types of gliomas in the category of grade 2, then you can predict the overall survival pretty well. Likewise for the other grades. These grades correlate with prognostic factors. So here's a list of factors that have been established for gliomas for years, if not decades, that prognosticate very well. How common are all these various gliomas that I mentioned to you? So if you look at the incidence of all primary brain tumors, this gives you a rough idea of incidence. So in this pie chart, they've included all primary tumors. So meningiomas, pituitary adenomas, nerve sheath tumors are included. And you can see that those tumors actually are much more frequent than the gliomas that make up the smaller part of the pie chart for all primary brain tumors. If you zoom in and just focus on the incidence of all primary malignant tumors, then this is where you can really see how glioblastoma stands out. So for all of the malignant tumors, this is the one that makes up 50% of the pie. So that's why our focus is always there when we're trying to figure out how to better treat these tumors. All right, so that's a lot about classification of these tumors. So what about diagnosis? So of course that starts with imaging. Most folks in the field would say that they could do a pretty good job at identifying a glioma on an MRI image. Of course, the challenge is figuring out the type of glioma and the grade of that glioma. So that requires the histology work. And of course, as I just illustrated, genomics is now required to further define these gliomas. So to kind of illustrate that, what I'm going to do is I'm going to go through some of the typical glioma examples in each grade category that you're going to come across. So here's a prototypical WHO grade 1 type glioma. That's the Pilocytic astrocytoma. So it's much more common in children, occurs primarily in those first 2 decades. It can arise anywhere in the CNS, but here are some of the preferred sites like the optic nerve, thalamus, hemispheres, cerebellum, brainstem, spinal cord. In my adult population, by and far the most common place I see this tumor is in the cerebellum. In fact, I had a patient 2 weeks ago who had a recurrent polycytic astrocytoma in his cerebellum. On imaging, these tumors are usually very well circumscribed and contrast enhancing. So here is an axial T1 with contrast MRI picture showing a cerebellar tumor, very classic picture of this type of tumor where you have this enhancing nodule associated with a large cyst. And this specimen is a great example of how it's a very well circumscribed, well defined nodule with that cyst. Histopathologically, what do they look like? So this astrocytic tumor is relatively low cellularity. It has a unique biphasic pattern. So there's a compacted area of bipolar cells and Rosenthal fibers, and then there's another pattern of loosely textured areas with multipolar cells, cyst, and eosinophilic granular bodies. Very rare to see things like mitoses, atypia, microvascular proliferation. The Rosenthal fibers, these are these corkscrew-shaped eosinophilic fibers in the astrocytic processes made up of alpha B crystalline. Those eosinophilic granular bodies, these are aggregates in the astrocytic processes made up of alpha-1 anti-chymotrypsin and alpha-1 antitrypsin. So here's a little bit of what that looks like. So if you step back, you can kind of see the biphasic pattern. There's the compact areas and the loose areas. Here's an example of those Rosenthal fibers, those long squiggly eosinophilic fibers inside the astrocytic processes. As far as markers on immunohistochemistry, so these are the heavily GFAP positive gliofibrillary protein, and the Ki67 index would be very, very low, 1%. So that refers to the number of cells that are cycling or mitotically active. As far as any sort of genetics, you have to think about NF1. So NF1 patients, 15% of them will develop these types of tumors, and especially in the optic nerve. Remember, NF1 gene is on chromosome 17. It's a tumor suppressor gene. In contrast to the other astrocytomas that we'll talk about, TP53 mutations are very, very rare in this tumor. It does have chromosome 7 and 8 gains. So the prognosis is excellent. Surgery can cure these patients without any other adjuvant therapy. All right, what about WHO grade 2? So sort of the classic one there is the well-differentiated astrocytoma. Historically, we used to call this low-grade glioma. That term has kind of fallen out of favor a little bit. So this is a little bit more frequent, 10 to 15% of the astrocytic tumors. It occurs in a little bit older population, average age of about 30, equally in men and women. As far as where it occurs, you see the most common location supratentorially in the frontal and temporal lobes. On neuroimaging, this is what a typical grade 2 glioma might look like. It's non-enhancing, and it's going to typically be very bright on T2 or FLAIR images. So here on the left is a T1 plus contrast axial MRI image. So very well demarcated lesion that's dark, not contrast enhancing. And here's that same picture, but the T2 sequence. And you can see how bright and flare enhancing this is. I would say most glioma surgeons probably encourage folks to use this image when you're resecting these tumors in the operating room. Histopathologically, these are tumors that have well-differentiated cells. So well-differentiated fibrillary gematocytic astrocytes on top of a mild microcystic tumor background. A little bit more hypercellularity, occasional atypia, but really no mitotic activity, no microvascular proliferation or necrosis. And this is a sort of a typical picture of what that might look like. These cells will also be positive for GFAP as well as Vimentin and S100. So those are going to be strong markers for most of the glioma tumors. That is, most tumors that are well differentiated. So as you get more malignant, more undifferentiated, these markers are less obvious, less prevalent. Ki-67 index is going to be higher, so it's up to 2 to 3% in these grade 2 tumors. All right, here's a grade 3 tumor. So this is your typical anaplastic astrocytoma. These are in a little bit older folks, and now the average age is up in the 40s. They're located in similar places as the grade 2s. And on imaging, so now we're starting to see signs of enhancement. So sort of the classic description will be a ring enhancement pattern with a central area representing necrosis and surrounding edema. So you can see a good example of that here in this coronal view. Again, this is a T1 sequence with contrast. So ring enhancement with likely surrounding edema. Now remember, all these classic pictures I'm showing you, they're not diagnostic. They are classic, but not diagnostic. So always remind yourself to include a good differential diagnosis when you're looking at these MRI images. So as all of you guys know, this could look very similar to a secondary metastatic tumor. It could look similar to an abscess. So again, don't forget about differential diagnosis when you're looking at imaging. Histopathologically, so these tumors are going to be much more densely hypercellular. There's going to be much more obvious nuclear atypia, increased mitosis, prominent nucleoli, and might even see multinucleated tumor cells. This is a little bit of what they look like. So you can see a bit more hypercellular, but what's really now different is this remarkable cellular and nuclear atypia. You're also going to see more mitotic activity and more vascularity there. So again, these will be positive for GFAP Vimentin S10. Ki-67 index is going to be a little bit higher. So now we're kind of up in the 10% range. The genetics are now also going to start getting much more diverse and interesting. So these are a few of very well-established mutations seen in grade 3 tumors. These have been known now for many, many years, including TP53 mutations, P16, RB, P10 mutations, CDK4 amplification, chromosomal abnormalities in these. And now we're starting to see this EGFR amplification. Of course, there's many other growth factor pathways involved as well. And this is going to really take off in that grade 4 tumor. So now prognosis is different. Prognosis is much worse. It's now these tumors are going to be treated like a malignant tumor and require adjuvant therapies, and going to be treated the same as grade 4 GBMs. Okay, so lastly, here's an example of grade 4. So this is your glioblastoma. So like that pie chart I showed you, these are the most common astrocytic tumors. Peak incidence is going to be an older population. The average age is about 64. These are a little bit more common in men. And again, they're more common supratentorally, especially in the frontal lobes. On imaging, these look similar to the grade 3 tumors, but there are signs to suggest more aggressive behavior. So it's going to be a little bit more irregular shaped lesions. You still have this peripheral ring-like enhancement. You'll have this central zone of necrosis. And over here on this T2 sequence, you can really see how much edema these malignant tumors can incite. To give you another example, I have a current patient who came in about 2 weeks ago, walked in with a headache, and he has a malignant glioma that's centered in his insular lobe, but it actually spreads out into most of his hemisphere. And he's got so much edema that he's got remarkable midline shift. And within days, he started herniating without any sort of intervention. And that led us to a quick hemicraniectomy. So these tumors can change quick, and you have to be very aggressive at taking care of these folks. I thought this specimen is a good illustration of how infiltrated these tumors are. So you can imagine that on the MRI, this central area of necrosis is probably where your focus is going to be on that MRI, but you can easily see how infiltrated these tumors are and how much those tumor cells spread beyond that focus, even to the contralateral hemisphere. All right, so to wrap it up, histopathologically, again, diffusely infiltrating, very hypercellular, poorly differentiated cells, lots of pleomorphic tumor cells, very high mitotic rate. Now you see a lot more microvascular proliferation and necrosis that's called pseudopalisating. The immunohistochemistry is a bit more variable, but you might see some GFAP positivity. Ki67 is much higher now, up in the sort of 20% range. And again, the prognosis is very poor despite all the therapies, with an overall survival of about 1.5 years. So this is what it looks like. So cells are much more dense, much more pleomorphic. Here's a good example of that classic pseudopalisating necrosis that I mentioned. These tumors characteristically are going to have hypervascularity. So here's a good example of that. And sometimes they'll have some unusual cell types. So here's just one example that's called a giant cell glioblastoma that has these big, unusual, odd giant cells and multinucleated type cells. The interesting thing here is that if you diagnose that, they do have a little bit better prognosis than the general population of glioblastoma. These aggressive tumors can have sort of sarcomatous transformation. It looks a little bit like that. And again, the GFAP is positive, but it's more variable, not quite as dense as in those other more differentiated gliomas. All right. I think for the sake of time, I'm going to skip this one. So I just threw in this other example because you hear it a lot, pleomorphic xanthoastrocytoma, but it's actually quite rare, only less than 1%. But I'll let you guys come back and look at those slides about the grade 2 pleomorphic xanthoastrocytoma. So I do want to talk about this. So this is a bit more common, the oligodendrogliomas. So the typical one is a grade 2. These account for about 4% of those primary tumors. Peak incidence is in the 40s, and a little bit more common in females. They occur also more commonly supratentorally, perhaps only supratentorally. But the unique thing about them is they are more commonly seen closer toward that cortical border near the cortex, which is probably why they more frequently present with seizures. So in imaging for oligodendroglioma, So this looks a lot like that other grade 2 tumor we looked at, the grade 2 astrocytoma. So again, very well demarcated, non-enhancing, so dark on T1, but bright on the T2 sequences. But here, this is a very good example of how these oligotumors seem to get right out to the peel surface. And again, you can imagine how these are very irritative to that cortex. So histologically, the oligotumors, the moderately hypercellular, some mild pleomorphic cells. Tumor cells have round oval nuclei, speckled heterochromatin, and perinuclear clearing. Those are halos, and that's what gives this so-called fried egg appearance that you will see on your board exams. These tumors have calcifications in them, so you might, if you suspect an oligo, go back to that original head CT and see if you see evidence of some calcification. You'll have this chicken wire vasculature in these tumors, which is common for oligos. And you'll see these other histologies. If they have significant mitotic activity, vascular proliferation, necrosis, then of course you're talking about the anaplastic oligodendrogliomas. So here's a picture of what these look like, and this is an example of how it gets right out to the pia. So here's the pia, and you can see this dense collection of tumor cells right up next to the pia there. Here's a good example of what those cells look like with that halo effect giving you that fried egg appearance. And you also, if you kind of step back, you can start to appreciate a little bit of that chicken wire vasculature. They have calcification, like I mentioned. Immunohistochemistry, there's no marker that differentiates them perfectly from other tumors. These also can express GFAP and S100. The Ki67 is lower, consistent with grade 2. They're rarely associated with any sort of hereditary syndromes. As far as their genetics, so you probably have heard about chromosome 1 and 19 q deletions. So chromosome 19 is the most frequent alteration. It consists of a loss of heterozygosity on the long arm of chromosome 19. So in other words, it's deleted. That occurs in most of oligotumors and may represent a tumor suppressor gene. Chromosome 1 is the second most frequent alteration. And similarly, the short arm of that chromosome gets deleted. It also occurs in a lot of these tumors, and again, can represent possible tumor suppressor genes. So in contrast to the astrocytic tumors, loss of chromosome 17p is rare. That's where TP53 is located. Likewise, overexpression of EGFR is also common. Okay, prognosis is similar to the grade 2 tumor as far as the median overall survival being several years. The tumors that have the loss of chromosome 1p and 19q are going to be associated with increased sensitivity to chemotherapy, so they're going to have a better overall prognosis. All right, so that was kind of a quick run through of examples of the more common gliomas in each grade. So now we're going to move on into a couple other topics. I mentioned earlier a couple of genetic syndromes. So there are a few syndromes where gliomas can occur. Of course, it's not very common to see these. So we typically don't screen family members who present with the glioma for these syndromes, but it's something to keep in mind. So I mentioned in that classification scheme the important addition of IDH status. And so this is probably important for you to know about. So let me tell you about that. IDH stands for isocitrate dehydrogenase. It's a family of enzymes that catalyze the conversion of isocitrate to alpha-ketoglutarate while converting NADP to reduced NADP. And those things are part of the Krebs cycle. occurring and also occur in the cytoplasm. You can have somatic mutations of 2 isoforms, so those are called IDH1 and 2, and those occur in a variety of cancers. So this is not novel in oncology, but is a relatively recent addition to glioma genetics. So in gliomas, initially seen in a higher percentage of the lower grade tumors, so up to 90%, as well as secondary GBM. So remember, most GBMs are primary de novo GBMs, but a few, 10 to 15%, are secondary. So they arise or they transform from lower grade gliomas. So those tend to have IDH mutations the most. So the majority of the mutations are caused by amino acid substitution at a specific position. So you'll often see this nomenclature when talking about IDH mutations. And then another one is at this amino acid position. So these mutated IDH genes, they result in proteins that convert alpha-ketoglutarate to the putative oncometabolite 2-hydroxyglutarate. And it's interesting because you can actually detect that on spectroscopy. So there's potential there. Of course, there's already a literature on it, but there is potential there to use imaging to start to define gliomas by their molecular biology. IDH mutations have been shown to be one of the earlier events in glioma formation, is the theory. The production of this 2-HG metabolite appears to drive epigenetic changes that alter cellular differentiation and contribute to oncogenesis. So independent of the grade 1, 2, 3, or 4, IDH mutations in gliomas confer a better progression-free survival. And there are cases of some IDH wild-type lower grade tumors behaving a lot like the more aggressive GBMs. So this has become a very powerful prognostic tool for us. All right. What about treatment? So as I mentioned, for the grade 1s, there's potential of curing with surgery. There might be examples of where genomics can help. So most centers nowadays are taking those tumors and doing genomic studies on them because that might be helpful. As a quick example, I mentioned to you that I had a patient a couple weeks ago who had a recurrent polycytic astrocytoma in his cerebellum. So that tumor is still grade 1 polycytic astrocytoma, but it happens to have a BRAF mutation. So if his tumor does recur in a way that is not amenable to surgery, then he might benefit from this very targeted drug therapy. All right, for the grade 2s, so a bit more controversial here. Most would recommend resection, especially if your patient is symptomatic, and especially if you have a patient who's demonstrated growth of that tumor or who has demonstrated signs that might suggest transformation. So maybe the beginning of enhancement. But most would strongly encourage resection. If for some reason you have a patient who might be asymptomatic and it's an incidental finding and maybe doesn't want resection, then you should discuss at least a biopsy so you can at least get that diagnosis and get the genomic data. Because again, those markers there can help with prognosis and help predict response to other therapies. So after resection, radiotherapy is often considered, and that's a bit more controversial. Lots of literature out there looking at that, lots of studies going on, trying to define the role of radiotherapy in grade 2 tumors. All right, let's focus on grade 3 and grade 4 gliomas, the malignant ones. So the standard of care for malignant gliomas was established really in 2005 by this work. And this it refers to the Stoop paper. And so this is called the Stoop protocol. And the therapy is maximally safe resection, followed by concurrent radiotherapy plus temozolomide, followed by at least 6 months of continued temozolomide. So maximally safe resection, so that's important to keep in mind. And then concurrent, of course, means given these two therapies at the same time. And so what you see in this population is basically increased survival by about 2 months in those patients who get that standard of care therapy. So not a dramatic improvement in survival, but nevertheless, there is some improvement. So that's the standard of care now. So centers out there are going to have their own sort of treatment algorithm or scheme, and this is just sort of an example that I'll let you guys go through on your own and look at the details. So the hope is that patients with these malignant gliomas will get through that standard of care. They'll get a good surgical resection. They'll complete those concurrent therapies, and then they'll be able to move on to something else. When you have to modify that therapy, and that's the purpose of my red arrow, is to remind me to say that sometimes you have to modify that therapy, and the various reasons, but the two most common reasons would be a patient who has a poor KPS or performance status, or maybe they're too old, maybe they're elderly and a little bit too frail to go through these aggressive therapies. So you might want to modify your therapy. So I'll say a little bit about that. KPS, so let me just introduce this to you. So throughout neurosurgery, throughout all sorts of conditions, you're going to see various clinical grading scales out there. When it comes to neuro-oncology, KPS is clearly the most common. So this is the grading system, goes from 0 to 100. 0, they're dead. 100 means normal. And you'll see that I circle 70. So 70 is really the most common number that we focus on when we're trying to figure out, is this a patient who can tolerate very aggressive therapy? And what 70 means is this is a patient who can care for themselves. They may not be able to do all normal activities. They may not be able to maintain an active work schedule, but they can pretty much care for themselves. They can be independent. So that number is important also when we're doing clinical trials. So that's probably the most typical criteria used in clinical trials is patients have a KPS of 70 or more. Of course, we want patients to do well in our clinical trials, and most clinical trials are going to select the best patients for that. So that's the KPS or Karnofsky Performance Status Score that you'll see a lot in this topic. All right. So what do these patients look like? So let me give you a little introduction to that. So here's an example of a relatively recent cohort that was published, just to kind of give you a rough idea of what these patients look like. Now, this cohort, these patients are a little bit older, but you can see that they present with all sorts of symptoms. And we're going to dive a little bit more into that in the next lecture when we talk about some specific cases and how those patients presented. Remember, it's an older population in these malignant gliomas, so you have to think about their comorbidities when you're thinking about their therapies. These tumors, again, are occurring in all sorts of locations. In this patient population, a large number were located in eloquent areas of the brain. We'll talk more about that in the next lecture as well. And in this patient population, you can see gross total resections were really only 63%. So that's actually a reasonable number. We wish we could get gross total resections on all of our patients, but the fact is there's a lot that we cannot for lots of reasons. There's different definitions of that, but I think probably the most common definition of a gross total resection is going to be resection of that enhancing part of that tumor that you see on the MRI. And how much of that represents gross total? Well, I think most people would argue 95% of that enhancing part of that tumor probably would represent a gross total resection. These patients get other adjuvant therapies. In this cohort, most were able to get through that standard of care of radiotherapy, temozolomide, and then many patients move on afterwards to other chemotherapies, and this is a very short list of other chemotherapies that are used out there. Of course, none of these represent standard of care, so this is all beyond that standard of care at 6 months. So I pulled up this example because it illustrates those prognostic factors I mentioned. So we clearly know that age is important prognostic factor. So in this survival curve, younger folks obviously do a lot better than the older folks. We know that those who have a higher KPS have a better survival curve than those who have, the lower KPS. And again, 70 is about where we really start to see the difference in how well these patients do when they go through these aggressive therapies. Lots of data out there shows that when we do gross total resections, they have better survival than subtotal resection. And then for patients who get beyond that standard of care, beyond 6 months survival, and they are able to move on to something else, they tend to do better. We don't know what that something else is, so we're not certain, or we haven't established any specific other chemotherapy out there that's beneficial, but if they get moved on to something, they tend to do better than those who are not getting any additional chemotherapy. And we know that when we have populations where we might have to modify care, for example, the elderly, that if they will do better if we can get them through some of those standard of care options. So this is just an example of an older population where the survival is better if we can get them through all those standard therapies. Should you do surgery if unable to get gross total resection? So I've been emphasizing this gross total resection. And we have lots of data that shows it should be sort of the standard. So here's a good meta-analysis showing lots of studies, and in all these studies, gross total resection favors improved survival. Even in older, more frail patients, if we can get gross total resections, that favors survival. But as I also emphasized, it's unrealistic to get that in all of our patients. And so we have to think about how to handle subtotal resections. And there is certainly lots of favorable data out there that supports benefit from subtotal resection. So then you have to ask yourself, well, what's a reasonable subtotal resection? We haven't really answered that question, I don't think, but I would argue that if your post-operative MRI shows that you've gotten maybe 70% of that tumor, that's probably a beneficial subtotal resection. Of course, more is better. If your MRI shows that you're maybe at 50%, well, you probably should be thinking about trying to get that patient back into surgery to see if you can do a little bit better job. You have to remember that these are very aggressive tumors, and when you operate on them, they react. So they easily hemorrhage. They can have malignant levels of edema right after surgery. So if you leave a sizable amount of tumor, you might be dealing with those sorts of complications that can be very traumatic for your patients. But if you, for example, get that 70% subtotal resection and you get your patient on to the rest of the standard of care, then that clearly is going to be beneficial for that patient. I've mentioned ways to modify standard of care, so I just want to say a little bit about that. So radiotherapy is part of standard of care, and there is the sort of the standard regimen of radiotherapy, 60 gray given in fractions of 2 gray over a course of about 6 weeks. This is just an example of studies where they looked at pretty much about half the dose. So for example, if you're looking at an elderly patient who may not tolerate that much radiotherapy, we have data that shows that if you basically cut that in half, you can still get some benefit. if you have to shorten the radiotherapy, but if you can continue to add temozolomide, there's benefit there. So again, here's an example of a survival curve looking at a patient population where they had to do a shortened course of radiotherapy. They added temozolomide, and those patients continued to do better. And here's the radiation dose that they used, and you can see that that's much less than that standard of care therapy I just showed you. I'm going to move a little bit quicker to make sure we wrap up in time, and hopefully I can get to some of your questions. Another thing to keep in mind is MGMT status. So I haven't mentioned that before, but that's now a universal marker that we do on all of our patients to look for. So to remind you, MGMT is a DNA repair enzyme. And if that is shut down by promoter methylation, then that tumor cell is more vulnerable to things that's going to mess up its DNA, like chemotherapy. And so it's not going to be able to repair itself. So we know that in patients who have MGMT promoter methylation, so it's not being expressed, if you give them temozolomide, their survival curve is better than those who have MGMT that's not methylated. So in a nutshell, if patients cannot tolerate standard of care, and if you get that MGMT status, if it's methylated, they probably will do better temozolomide. If it's unmethylated and you can't do both things, then you probably should focus on radiotherapy. So there are other FDA-approved options out there. This is not a comprehensive list, but here are some examples. These are not part of standard of care again, but they have been approved for various reasons. So for example, there's this picture in the top right shows these carmustine impregnated wafers that you place into the resection cavity. So these wafers have this non-specific chemotherapy. Think of like temozolomide, which is also non-specific chemotherapy, is in these wafers, and that will leach out into the surrounding resection cavity. It's a terrific theory because we know that when these tumors progress, the majority progress adjacent to the resection cavity. So this local regional therapy makes sense. There is very robust data that's years old now showing that this has some clinical benefit, but it hasn't really caught on. And I've just listed a few examples of why. Very costly. It's a little bit toxic to handle. There's significant side effects. It can make the brain react nearby and swell, and so it can be difficult to manage patients who get that. Everybody's probably heard of bevacizumab, the anti-VEGF antibody. So that was approved a bit early based on some early results, but subsequent randomized clinical trials showed that it really was not efficacious. However, big however here, it clearly is used a lot nowadays because it does play a role. It can help with things like symptomatic radiation necrosis and edema. A more recent example are tumor treating fields. So these are cap-like things that are placed on patients that deliver this low intensity intermediate frequency. And it appears to have sort of an anti-mitotic effect. There are a few other agents that I won't go into. And just to illustrate that data from the tumor treating fields therapy. So this just recently came out not long ago. And you can see in older patients, those folks have a better survival curve who got it. And even in patients who have MGMT promoter methylation, who also get temozolomide, they show an additional benefit if they got the tumor treatment fields. So there's a lot of folks out there arguing that this should become part of standard of care. I think we probably need a little bit more time with that therapy. All right, so there are lots of emerging targets out there for the glioma subtypes. This is not a comprehensive list, but you can see subtypes here. You can see associated genomic mutations that have been discovered. And there are very specific therapies out there that can be tried. So this is kind of an area that I find very exciting. So here's an example of a recent study, just came out earlier this year. where they use molecular profiling-based decision-making to decide on a targeted therapy in their GBM patients. So they identified these mutations, they pulled very specific drugs off the shelf that target those mutations, and then they use that strategy to treat their patients after they got standard of care, of course. Their conclusion said that overall survival was similar with or without this molecular guided treatment. So I would say more work needs to be done. But here's a very exciting piece of data from that work. So if you just look at the patients who have MGMT unmethylated tumors, so again, those patients will not do as well with temozolomide. But if you gave them a targeted therapy, the red line, in this study, they had what looked like a very promising survival curve. So there's certainly something there, and there's a lot more work that needs to be done on molecularly guided treatments. We're just now getting into that. This is about my last slide. So there's numerous other ideas out there that have been studied for years. They're still being studied, and you can see the variety, incredibly diverse areas of study in how to treat these tumors. And I mean, if you're looking for an area of research to get into, you could just stand back and throw a dart at this slide. And I promise you, no matter where it lands, you'll find a very exciting area of study to get into.
Hey everyone, Ryan Rad here from Neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.